2 today is our second meeting dedicated to taking evidence, oral evidence from various stakeholders to inform our inquiry on mental health inequalities. And I'm very grateful for our witnesses to provide time with us this morning. And could I just ask you to introduce yourselves for the public record?
My name is Rob Poole. I'm Professor of Social Psychiatry at Bangor University. I co-direct the Centre for Mental Health and Society, which is a research group whose interests are around the social dimension of mental health.
My name's Ewan Hilton. I'm Chief Executive of Platform.
Good morning. My name is Dr. Jen Daffin. I'm a clinical psychologist. I'm here as Chair of Psychologists for Social Change Cymru.
Lovely. Thanks ever so much for being with us all. Members will have a series of questions, and don't feel you all have to answer every question. Some questions will just be dedicated perhaps to some of you. But I'm going to ask an opening question, which I'm keen that you all opening comments to really. But can I ask you what do you think are the things that people need to build and maintain good mental health? And as a society, are we good at ensuring that those fundamental needs are met? Who would like to have a stab at that first of all? And I should say, anytime if you want to come in, just lift your pen or hand up or something so I can see you want to come in. That's all right as well. And members will do the same. Who wants to come in on that question first? Go on then. Thank you, Professor Poole. Thank you.
I cracked first. Okay, so what do people need? Well, we know that mental health problems across the board are strongly associated with social inequalities and social injustice. We know that the most marginalised and deprived groups in society are most vulnerable of mental health problems. That isn't to say that other people don't get these problems, but it's about who actually does in large numbers. So it's a bit like in the old days, tuberculosis. Anyone could get it, but by and large, poorer part of the population got most of the TB that there was. And the most important thing in the long run is around prevention. And prevention is dominated by the need for better levels of social equality. This is not simply a statement of what is a social good, which I think most people would agree it's a social good. There is actually a mass of clear evidence that if we look at pretty much all mental health problems are much, much commoner in people from more deprived parts of the population, and in particular for the more serious end of the spectrum, people who have problems with psychosis. This is particularly strongly concentrated on those who grow up in conditions of inner city deprivation and people who grow up Black in the UK. There's a very strong association with those two factors. If we want to develop proper long-term prevention, what we need to do is address what Michael Marmot has described as the cause of the causes, which is the conditions under which people live, particularly during their childhood, but also in their adulthood. Now, that's a big ask. That's asked for a large transformation in a change that's been in the wrong direction over the last 10 years, and I hope committee members will have had access to Michael Marmot's report of 2020, which demonstrates that actually right across the board, most public health indices have worsened as inequality has worsened since following austerity policies. So that's about prevention, and we've got a strong emphasis on prevention, but there's also obviously a large number of people in society who have mental health difficulties. And one of the things that was really important for people is social infrastructure. Once you've got mental health problems, to return to employment. We know most people with mental health problems want to return to employment if they can. Housing, benefits, and are we good at addressing these problems? No, we're not. We have also seen our services have become very atomized, very difficult to access, probably overly focused on controlling people rather than getting alongside them and offering the things that they need to recover. And that isn't just about lack of money. That's about how we organise services. We would regard the the atomisation of services, the so-called functionalisation of services, where you have many, many specialist teams, as having been a major problem, which creates multiple interfaces that can reject people, that can lead to badly coordinated care. There is unquestionably, because of difficulties in accessing services, a pressure on primary care, which, as we know in Wales, and especially for us up here in North Wales, there's particularly severe problems around primary care. People with mental health problems presenting them at primary care are likely to get a very I hesitate to use a word that might be regarded as pejorative, but are likely to be offered prescriptions rather than more complex interventions to help with their problems. So we've got a long way to go. I would have to say that our view would be that there are some things that can get fixed. It isn't all about massive global stuff. There's some very straightforward things that could be put right. For example, just to take a simple example, if we were to manage to devolve the work of the Department of Work and Pensions to Wales and overcome some of the real serious problems people have in securing benefits, that as an achievable reform would make a significant difference to a large number of people with mental health problems. I'll stop at that.
Thanks, Dr. Paul. I was going to say I did invite you all to speak, but if you feel that Dr. Paul has addressed, you agree with what he said, then by all means do so. But if you want to add to it or disagree with anything, even Dr. Daffin.
Do you mind if I add to it? Thank you.
Absolutely, please do.
I agree with what Rob has said already. I just wanted to add to it. So we would see this as about addressing the social determinants of mental health and not forgetting those when we talk about the social determinants of health, making special place to remember that our mental health is not separate from our health. So when we're having those conversations, to really include the conversation around mental health and mental illness in that. But when we're talking about addressing the social determinants of mental health, this doesn't just mean building good housing, safe and secure places for people to live, or access to education and having enough money. It's also about our relational needs too. So it's about having safe and supportive relationships with our families, our friends, our communities, and ourselves. It's about having those basics of being able to access security, meaning, purpose, and trust, as well as having access to the physical things. And it's important that when we're discussing social determinants of health, we don't forget those relational parts as well. So this, for us, means creating communities that are safe and inclusive for everyone to live in, whatever diversity or difference that you have. So when we're thinking about, are we doing this well, everybody should be able to feel, I belong here. And it's that kind of cultural shift that we're looking to achieve, because the opposite of having traumatized communities or communities that are in distress is psychosocially healthy communities. So in order to address this problem, if we're understanding mental health is largely determined by our circumstances, we need to be thinking about how do we create psychosocially healthy communities, psychosocially healthy places to live. What that means is creating spaces where people feel that they have agency, security, connection, meaning, and trust. And it means moving away from what Rob's already said about circumstances and systems that perpetuate fear and control over people. So it's creating those opportunities for people to thrive. Often when we talk about mental health, we say like the one in four of us will get a mental health problem. But the thing that disguises for us is that it's not randomly distributed, and it's not just about the fate of our biology or lack of personal resilience. That's not true. What we're seeing is correlated to, well documented to, our circumstances. So therefore, this is less about who, and it's less about targeted groups, although particular groups will experience more injustice. And it's more about creating the right circumstances for everybody to thrive, for everybody to feel that they can belong to, in order that we can then address the mental health inequity. And in order to do that, we need to be focusing on eradicating circumstances that cause prolonged exposure to things like toxic distress, which we know are associated to adverse childhood experiences, but they're also associated to adverse community and public health experiences as well.
Thank you, Dr. Daffin. You and Hilton don't feel obliged to come in, but yeah, by all means, if you're going to add to what
I
was
completely agree with all of that, particularly what Jen was speaking to there around the importance of community and relationships. And you took the words out of my mouth about the 1 in 4 narrative. I think there is something really unhelpful about that narrative. And there's a public narrative around mental health that needs to shift and embrace the social determinants of mental health and the fact that we are more likely to experience this if we've had a tough time. And just a point on the budget, really. I think the mental health budget is one of the biggest spends in the health budget, and we keep throwing more at it. And increasingly, we're seeing this as failure demand, and it will continue to be being failure demand and increasing demand until we address the social determinants of mental health, which help to prevent people from needing the level of service that the current demand is showing.
Thank you. Jack Sargent, you want to come in?
Yeah, thanks, Chair. Just very quickly, just picking up on Ewan's point there and Dr. Daffin's. On the 1 in 4, I agree. I don't think it's the right terminology to use. Would you not agree it's 4 in 4? We all have mental health, and some people just have worse days than others, and actually perhaps the focus of prevention and the strategy for mental health should have that focus and that lead.
I think that it's interesting that we're coming to the final year of the 10-year mental health strategy Together for Mental Health, and it's under review at the moment. Our feeling at Platform is that the new strategy needs to be built absolutely around addressing the social determinants of mental health, which includes services, but the situation will not change until we address the social determinants that are causing people to experience emotional distress. And it is 4 in 4, but it's not evenly distributed. You're more likely to get sick, suffer, experience emotional distress, mental health problems if you're living in poverty, if you're facing discrimination, hate crime, don't feel connected to your community or the people around you.
Dr. Daffin, just briefly, because we've got quite a lot to get through, but then I'll come on to you, Professor Paul. Dr. Daffin.
Just to reiterate, yes, we agree with that. So what we need to understand is this is about a continuum, and if we load, if we put lots of stress on people and we overload them, then they're more likely to have these experiences. But we are all equally subject to them. The thing to take into account there is transgenerational trauma. So it may look like people are born then more vulnerable, I think we often say, to mental health. But if we really understand that this is not what's wrong with us, but what's happened to us, we need to take transgenerational circumstances, so the epigenetics, the loading that people then carry into that, bring that into the conversation as well, and then we can start to see where those hidden patterns of circumstances are hidden in our histories, as well as then in the present circumstances, which I think helps us understand that it's not 1 in 4, it's 4 in 4.
Thank you, Professor Paul.
I'll be brief. I just would like to say that I think that the problem with the 4 in 4 argument is it overlooks the position of people with particular vulnerabilities, particularly people with long-term problems around psychosis, who are easily forgotten in an argument that says that this is simply about a continuum of distress. I agree there's a continuum of distress, but there is also something about people with long-term problems with psychosis that makes them particularly vulnerable.
Thank you, Dr. Paul. Professor Paul, I know that we've got a lot of questions to get through in the next hour, so please don't feel you all have to comment on every question, especially if you agreed with what's being said. That'll allow us to get through all the questions that we're hoping to ask today. Gareth Davis.
Thank you very much, Chair, and good morning, everybody. Just to kick off on the first question, to what extent do you think there's an over-reliance on a medical model for mental health in Wales? And I know Professor Poole touched on it in his opening remarks about the use of prescriptions and medications. And what impact does that have on people's experience and outcomes?
So I'm just looking, I think, yes, Professor Poole did touch on that quite a bit on his opening comments. Dr. Daffin or Ewan, do you want to add anything to that at all? Ewan.
Yeah. Oh, okay. Well, yes, I think the whole mental health system is constructed around the medical model still. And whilst that has some value and meaning for people, and it is a gateway into help and other services, so not just mental health services, often housing, financial security benefits, many, many other things, it is also limited. And I think too often it locates the problem inside the individual and doesn't contextualize it in relation to the social determinants that we're talking about. But I think Jen can speak more eloquently on that than I probably can, so I will defer to Jen.
Dr. Daffin.
No pressure. If we're understanding that mental health is also about our emotional regulation, and that dysregulation is caused by our circumstances, then we need to also go back and create the right circumstances for people. What we're looking at when we're using medications is helpful ways to get people there, but long-term use hasn't shown to be helpful, and has been shown to be harmful as well. And it doesn't do anything to help people change their circumstances so that they're not causing them problems. It's like a sticking plaster. So it's not going to the deep-rooted cause, it's just kind of masking over the causes.
So I can see Joyce wanted to come in with a quick question, and I'll come back to Gareth. Joyce.
Great question, but I don't know about the answer. You talk about emotional regulation, Dr. Daffin, but of course lots of people use other means to regulate their emotions. So substance misuse, alcohol misuse, and all those things. So there's a clear link, when you said those words, it was obvious to me that there's a clear link that, you know, if it's a medical model, people seek their own medication, and also don't want to go to the GP, or they can't get to see a GP. So I said it's an easy question, no easy answer. So how do you see the links with that? And we know that there are problems clearly with overprescription of medication anyway, because they of themselves can become addictive. But I just wanted to tease out the links between the difference of people emotionally regulating the way they feel.
Okay, thank you, Joyce. Dr. Daffin.
So what we're not then learning, or what we're not exploring, is what are the alternative ways to learn how to do emotional regulation. And there's lots of literature on that. So we talk about needing to be regulated in order to relate to others, in order to do reflection thinking, but often when we're talking about these things, go straight to therapies and things like that. We miss out that bottom layer of what does regulation mean, and how do we achieve that. Medication can be helpful and in some situations, but there are a whole host of other ways that we could do that. Some of those we're seeing through the whole schools approach, where we're looking at the environment. How do we create a balanced, psychosocially healthy environment for people to be regulated? If we're looking at emotional distress, then how do we create the circumstances to co-regulate with each other, especially in young children, to teach young children how to do that? But then also, how do we create the circumstances for adults to be able to do that? That's as much about our relationships with ourselves and others, as well as it is to our circumstances. And I think we jump that, we go straight to medication. We don't spend enough time thinking about how can we create that around us on a daily basis. Yoga is one example, but breathwork has also got a bit of evidence base behind it. But there are many other ways that we can do that, just in connection with each other, going out for walks, and there are there'll be unique ways to individuals, because we all have, you know, our own unique ways of wanting to do that stuff as well. Focusing the conversation around that.
If I ask Gareth Davis to come in with his next question, then I'll come to you, Professor Paul. I know you wanted to come in as well, but just to move things on. Gareth, you want to ask your next question, then I'll come to Professor Paul.
Thanks again, Chair. Many people and stakeholders call for a trauma-informed approach across all of the public services. So what does that actually mean in practice, and what action is needed to further and develop this and implement it across Wales?
Yeah, Dr. Paul, if you want to address perhaps Joyce's question and Gareth's as well. Professor.
Oh, sorry. Right. Okay. So to answer the question about the medical model, our view would be that the medical model if we abolish the medical model tomorrow, we're not necessarily going to do very much to achieve an improvement in people's mental health. That's the first thing. We must be focused on the social determinants and the things that make a difference once you've got a mental health problem. The medical model is a bit of a straw man. It is what most people define it as. I would include public health, therapeutic communities, psychotherapy within the medical model. Others would not take that view. It's certainly the case that we don't have sufficient psychotherapy resource available within the NHS in Wales. It's been extremely poor. Is psychotherapy part of the medical model? My view is it is, but as someone who's much training in psychotherapy. The trauma-informed approach, trauma is unquestionably important in causing mental health problems. However, it's important we stick with the evidence, and there is good evidence that some people's problems are not associated with trauma. So it isn't a one-size-fits-all approach. We need to understand that there are pervasive influences that cause people to develop mental health problems, and there are indeed biological problems that cause people to develop mental health problems, not least, for example, from the effects of medication sometimes. The final point I wanted to make is about what sustains the medical model. We've got some unpublished research which will be submitted for publication in the near future, not regarding antidepressants, but regarding opioids for long-term pain, which is actually a problem which is associated with mental health difficulties in both directions. And we've looked at what GPs say about their own prescribing, and they often are worried about their own prescribing, but don't know what else to do. And I think that perspective about what drives a medication-driven approach to all kinds of problems needs to be understood as part of the systems that we have established, that we drive practitioners into following approaches that they know are not the most appropriate approach, but are the only thing that they feel able to do.
Thank you, Dr. Paul. Ewan Hilton.
Yeah, I agree. Abolishing the medical model today would not help anyone at all. We have a system that's built on it. And I think, people are using the word trauma everywhere we go at the moment, and the risk is it becomes meaningless. So I would draw your attention to the Wales trauma framework that is out for consultation at the moment, which was a collaboration between Public Health Liaisons Hub and Traumatic Stress Wales, which is starting to try and describe what a trauma-informed public service in Wales would look like. We've been working hard alongside the team, helping to shape that. We feel that it offers enormous potential in helping to shift thinking in the system. What we don't want to happen is it just becoming another Welsh Government guidance document that everyone reads once or doesn't even read, and it sits on a shelf and doesn't need to change. So for us, the focus has got to be on what does that mean in terms of implementation across the system. And, moving from a mental health system that is over-reliant on a medical model to one that truly embraces the impact of trauma, but also the social determinants of mental health is a 10, 20 plus year project. I think the issue is we always look at the now and what's happening now, and we have short-term programs of government. I think what we need is cross-government commitment to a long-term transformation project that commits to embracing a trauma-informed approach to understanding emotional distress and the impact of social determinants, and builds all public policy making and legislation development around those things. So this is not a short-term fix. This is a long-term system change, cultural change, philosophical change project.
Gav, do you have any final questions on this section? Sorry.
Yeah, just on quick final question on just the details of concerns about the use of personality disorder as a diagnostic label. And I know from my experience, it's often used as a diagnostic label for people who present themselves as bipolar disorder, and then personality disorder is something that sort of that's diagnosed if bipolar can't be diagnosed, if you know what I mean. So what's the sort of issues around that in terms of getting the right support for people and making sure people actually get the right support that they need and the right medication and help and a structure around them in order that getting the right sort of package.
I'll start, but defer to people who know more of the technical detail. We have recently launched a campaign requesting a review into the use of this diagnosis in Wales. The indications are that it is often allocated to women more than men. It is seen as a diagnosis of last resort. The evidence around personality disorder diagnosis is that it's rooted in trauma, and there are alternative ways of understanding people who have experienced significant, severe, prolonged trauma. It often excludes people from services. So overall, we would say we would like it not to exist. We think it's unhelpful, and we think there's other ways of seeing people, hearing people, and responding to people who have experienced significant trauma. But I'll again probably pass to Jen.
What we're seeing is, I think it's 81% of people that have received that diagnosis in a study reported a history of trauma. But what we don't see is a routine inquiry or routine history taking of trauma from mental health services. And if we did see that, then would we be giving that diagnosis when what's actually perhaps being the problem, or what it masks, I guess what personality disorder risks the diagnostic overshadowing then of trauma and distress related issues that then don't get the proper support that they need. And we know that there are really good protocols for a complex PTSD. There's really good intervention for trauma. But if we're labeling it, if we're not doing a proper, if we're not taking proper histories, then we may be missing those opportunities to provide the correct support to people. There's also research around the use of that term as a pejorative term for women, and so there's perhaps some reflection to do on why and when are we using this, and are we using it in the correct way, and are we exploring and asking the right questions of everybody that's entering the system. So are we taking a routine trauma history?
Thank you, Dr. Daffin. Mike Hedges, do you want to come in at this point, Mike?
Diolch, Cadeirydd. Yes, we have heard a strong link between antidepressant prescribing and poverty. It was said that GPs feel they've got nothing else to offer people to manage their despair. But is it any surprise that people who are struggling to feed their children, who can't afford to heat their homes, who are worrying about their rent, are suffering despair and have mental health problems? I mean, is the mental health problem, in my view it is yes, but I'll ask you, is a mental health problem for a number of people being brought on by poverty and the conditions in which they live?
Professor Poole, you wanted to come in.
I'll answer that question first. Yes, that's an extremely good point. The fact about antidepressants, there are controversies about antidepressants. They're not a perfect fix. They have got some unpleasant adverse effects for some people, quite a large proportion of people, but they're very effective for severer forms of depression. What they're not effective for, and it's quite clear from the evidence that they're not effective for the kinds of depression that are responsive, simply responsive to very adverse circumstances. And so therefore you give people antidepressants, and of course what you get is the side effects and no real benefit. So, but there are people who become more depressed and who do benefit from antidepressant treatment. Oh gosh, I've forgotten what the other point was, and it felt really urgent to respond to it at the time.
Don't worry, we can come back to Professor Poole. Does anybody else want to come in and come back on that third point? Absolutely, Professor Poole. Dr. Daffin.
On the point of poverty and mental health, so there is a cause. So poverty is much a cause as a consequence of mental health, and so you're right, Mike. That is what we're seeing. And so why, when we know that these things are causing people distress, would we just look to medicate that and to hide that distress? What we're seeing is not a tsunami of mental illness, but a tsunami of distress. And so the long-term solution to this, to break intergenerational cycles of mental health problems, of trauma, of distress, of poverty, is to go upstream and figure out how do we break that cycle. For us, that's about an integrated, as Ewan said already, an integrated approach. So you spoke about the limitations of the medical model. The medical model, whilst it may evolve and has evolved, is organised around a reductionist approach. And what we're seeing is mental health is complex. It involves many different parts. We can take mind, body, soul, circumstances for ease, but it involves many different functions. And so we need a holistic, genuinely integrated approach that can hold complexity rather than fragmenting and soloing the different parts out and viewing them in isolation.
Professor Paul, you wanted to come back in there?
My memory has come back, and we were talking about personality disorder. Okay, categorical personality disorder is unquestionably a highly problematic way of looking at things. I think banning diagnoses is difficult, but certainly one has to understand personality problems in terms of developmental issues and indeed trauma, which is, you know, by far the commonest cause. But the thing that really causes difficulty with the mental health services is that mental health services are often felt driven to make very controlling responses to people who present in mental health crisis when they've got personality problems, which are exactly the wrong thing to do. And therefore we have to understand about the imperatives that are placed upon the mental health professionals who deal with people to do things that are actually the wrong things to do. This isn't simply about people's understanding of disorders, if we want to call them disorders, but it's also about the consequences for not behaving in particular ways. So one of the things that we see is a combination of factors that mean that we increasingly constrain people to respond in controlling ways to avoid bad things happening, and then causing bad things to happen because of the types of responses they make. So one of the things we need to do within the services is to introduce a much greater, as Jen was saying, a much greater, more history-informed way of understanding what the right response to people's problems is, and not to have a kind of knee-jerk reaction to issues that are real issues of risk, which must be managed.
Thank you, Dr. Paul. Mike, do you want to come in with any further questions, Mike?
Just one very simple one. How do we compare in prescribing with countries like in Scandinavia?
Dr. Daffin wanted to come in and perhaps address that last point as well.
Oh, that's not a point that I would be able to cover.
No,
sorry.
no
I couldn't give you the facts on prescribing rates, but I know that we have very high prescribing rates. And that's an issue for us. I wouldn't want to comment on how we compare, but I do know that there are statistics around recovery rates for what we call the developing world. The developing world apparently has a recovery rate of about 60%. The Western world has a recovery rate of about 30%. Given that we put more resource in, we have more money to spend, we've spent more time doing research, how come we're not getting the same recovery rates? Is that about the approaches that we're taking?
Dr. Paul, looks like you may have the answer to Mike's question.
Okay, so I just wanted to tackle the recovering world, the low and middle income countries. The question of what recovery rates are is actually much more complex than that. And as someone who's spent the last 4 years doing work in South Asia, I can tell you that one of the problems is ascertaining who has got a mental health problem and what happens to them. So I think we need to be careful about romanticising outcomes in low and middle income countries. The question of international differences in prescribing, America has got extremely high levels of prescribing. There's a variety of levels of prescribing across the world. By and large, across the world, prescribing is on the high side. But at the end of the day, we would see prescribing as a phenomenon that's arising out of inequalities and inappropriate services. Just simply trying to get people to stop prescribing without actually addressing some of the things that drive it. This is about inequalities. It's not about our models of services, although there are major problems with our models of services.
Thank you, Professor Paul. Joyce, do you want to come in at this point? Thank you.
We've spoken about barriers this morning, but there are barriers sometimes for specific groups, and those groups are people with co-occurring conditions and the challenges that they face. I mentioned substance misuse, but there are neurodiverse conditions and also dementia. Are you able to give or shed any light on addressing the barriers for those specific groups of people that I've just mentioned.
And again, we might not have time to bring everyone in in order to get through all our questions, but who would like to take Joyce's question? Professor Paul.
Yes, we would agree that people with substance misuse problems are excluded. Quite a large proportion of people with psychosis have got a substance misuse problem as well. It's probably about 50% of everyone. And if it's used as a criteria for excluding people from services, it's really very destructive. People can be bounced between services and not really get a service at the end. I mentioned earlier that we believe there's a serious problem with atomisation of services. We need to have services that address people's problems, don't address individual diagnoses. So we need to start with a focus on the person and their problem. Quite often, if you have a system that passes people from one bit of the system to another, it looks nice on a bit of paper. But every arrow on that bit of paper involves a change of team, a loss of information, all kinds of problems. We need to have a better model of addressing people's problems than the one we've got at the moment.
Thank you.
Sorry, Joyce. Dr. Daffin wanted to come in as well.
That's right. What I think we need to be doing is, there is so much overlap. Why is that overlap? And what's underneath that overlap? So are we looking at, like you said earlier, about coping strategies that people use, that people adopt, and what are they doing that for? Is it about nervous system dysregulation, emotional regulation? And so if we reframe the problem and look at, is that what's going on with people here, and they're just finding different ways of doing that, then we need to organise our systems around that rather than siloing and looking at the individual problems like substance misuse versus self-harm, for example, as two separate things, and find a more unified way of looking at things.
Well, there is another barrier, and that's those people who don't recognise that they have a mental health illness and therefore don't present at all. And I don't know if any of you can shed any light on those different groups that I hate this label, but would be deemed to be hard to reach. And we would welcome any comments that you have about helping those individuals who don't even perhaps recognise they need help in the first place.
I can just stand alongside you in my hate for that term and many other terms that we use to describe people in distress. So I think it's about our own organisations and systems cultures. Who is hard to reach? Actually, we're probably the hard to reach people, not the people that aren't reaching us. So I think it talks more about system culture and workforce. And, you know, it's really easy to point your finger at services and say they're not doing what's needed, but actually it's a scary, hard place to work. So when we talk about what a trauma-informed public sector looks like, it's not just about a trauma-informed service, it's a trauma-informed workplace where people feel safe to do what they think is right. Our services need to stand alongside people and with people without needing to label them as hard to reach or dual diagnoses. You know, it's about a human relationship with another human that hopefully leads to something better happening for that person in their life. Community embedded responses. There's a lot wrong with the way our systems are structured and managed that prevent good people from doing good work and getting to the places and people that we need to get to at the moment, I think.
There's just one area, Chair, I'm going to use a little extra time, that was briefly passed over, really, because of time, and that was the lived experience and particularly domestic abuse out with children. And if any of you have anything that you can share with us about the services that recognising the mental health stresses on children that will live with them through a lifetime as a consequence of domestic abuse.
We're at Dr. Daffin first, and then Professor Paul. Dr. Daffin.
I'm sorry if I've understood correct. Sorry. So yes, yeah, that, you know, that's noted as an adverse childhood experience. What we'd say is, linking back to what Ewan was saying, is it's about coming alongside people. If we're talking about understanding the trauma and the dysregulation that happens for people, then we need to understand that they may not be able to relate, and so clinic-based models that mean that you have to go to are probably too much. That's asking too much of people who are in quite distressed situations, and it's about coming alongside them. So coming alongside where they have existing relationships, and that's the same for in those services as well. But when we're coming alongside people, we need to come alongside them in a whole family way, recognizing that there are interrelational dynamics that will occur not just for the adult, but they will occur between the child and whomever else is in that family group. And so rather than thinking about this as just an adult problem, we need to think about it as a whole family problem, and then organise our intervention or our support around that, taking into account what might be happening for the child as much as what is happening for the adult, and that they are interactive.
Oh.
And I'd support that, and just emphasise the importance of domestic violence, specific resource for domestic violence, because it represents often an emergency and can lead to homicide. To go back to the issue about hard to reach groups, I think we have to follow the evidence, and there is quite good evidence about how you reach what hard to reach groups are. I worked for 16 years of my life in Toxteth in Liverpool as an NHS consultant with a population who were allegedly hard to reach. They weren't hard to reach. If you went out and spoke to community groups, formed relationships, formed continuous relationships between the teams, employed more local people from the local community within your service, listened to what people said, provided services that were close to where they were, then actually people became much less hard to reach. If you started working with people in their home, and as Jen said, not clinic-based, but actually going to people in their own space, which often was less threatening to people and less alienating, spend some time to engage people, then you can reach quite a high proportion of people who are otherwise regarded as hard to reach and end up being subject to legal powers. You can also quite often get people not to accept help without recourse to legal powers if you work with the community and with them. One of the most destructive things we have at the moment is what I would regard as a kind of production line approach to mental health that says we assess, we intervene, and we discharge. But more than anything, good mental health services are about forming relationships with populations that are long-term and building trust. And if you don't do that, it is always going to fail.
Thank you.
Dr. Daffin, you want to come back in, I think?
Just to add, we have an example of that in Wales. The Child and Family Psychology team in an area Bevan Health Board is doing some great work with the Families First services, where you're integrating that whole family poverty-oriented approach with psychosocial support. That would be a good model to explore more.
Joyce, do you have any final questions? We're a bit stretched for time. Or have you asked everything you want to ask?
No, that's fine. Thank you.
Well, thank you, Joyce. Jack Sargent.
Cadeirydd, my first questions was going to be around community solutions and the role of different partners and the role of communities, but I think the Professor Poole has answered that in good detail, and Dr. Daffin then has given us an example. Perhaps I can ask witnesses, because I'm conscious of time, if there are further examples of where we should be looking. Perhaps they could send a note to us after the committee meeting where we could see that. So I'll move on, Chair, because of time. We've heard from both the Centre for Mental Health and the Mental Health Foundation. Both of those organisations highlighted the benefits of social prescribing. So perhaps I could get your views, to maybe each of the witnesses as brief as possible, but your views on the potential for further development of social prescribing schemes. Dr. Daffin.
Like to go there, Dr. Daffin.
I think it's a good approach that's I think is showing good evidence, but I'm not familiar with it, but in that level of detail. But as a theoretical concept, if it's still used in a reductionist way, where we're not thinking about the person in their context and handing over power to them, we're just then telling them to go here or telling them to go there, then we're going to miss the broader benefit of that. And I think there's some great work in Swansea where they're putting workers into the community that I would really love to see that embedded in that approach as well.
Thank you, Professor Poole.
Social prescribing at least acknowledges the importance of the social. We have concerns of the need to have a mental health label to be prescribed. It's quite disempowering. We would regard access to social facilities and social opportunities to be really important. And we've talked in our written evidence about proportional universalism. There are some specific social interventions that are known to be helpful to people with severe mental health problems, including individual placement support in employment, there's a good evidence base for that. There's good evidence around supported housing. But if we can only access social facilities by being prescribed, we haven't really solved any problems.
Okay, thank you for that. Just you in any further comments? Or?
No, nothing to add.
No. Thank you, Chair. Thank you to the witnesses as well.
Thank you all. I hope you can hear me. My connection was a little bit unstable. But have you asked all your questions, Jack? Yes, lovely. Thank you. If I come to Rhian, I'll be on next. And if my connection is a bit unstable, then please indicate to Rhian who can share that section of the meeting. Rhian.
Wel iawn, cadeirydd, bore da I chi. Chydig o gwestiynau, amser yn dyn. Yn gyntaf ynglyn â lle da ni'n targedu yn ymdrechion. Da ni wedi clywed yn barod heddiw a droion o'r blaen mae y rhai mwyaf bregus a rhai mwyaf agored I broblemau iechyd meddwl sydd yn cael mwyaf drafferth cael cefnogaeth. Da ni hefyd wedi clywed cyfeiriad at y ffaith bod pawb yn gallu bod yn agored I broblem efo'i llesiant. Lle mae cael y balans yna rhwng targedu poblogaeth gyfan efo negeseuon pwysig ar iechyd meddwl a thargedu yr rheini sydd mwyaf peryg o wynebu problemau iechyd meddwl eu hunain? Professor Poole yn gyntaf.
I think that there are certainly some groups that need to be specifically regarded as at risk because we must follow the evidence. Now, the evidence base is not perfect. There are some important things that we don't have clear evidence on, but we've got some suggestive evidence around. So, for example, one of the things that seems really important in people's mental health is financial strain. We have very poor access to advice services these days. As you know, that the entire third sector has been drained of resources during austerity. And we would argue that one of the most important things to provide to people within mental health settings is access to advice on housing, on debt, and so on and so forth. The other thing which is often neglected, but has a big impact, we've got work about this, is the withdrawal of legal aid from people who are facing problems within the civil justice system. People who've got housing problems, who've got problems in the county court, find themselves unrepresented in court and having no way of finding a way to a system. So that support and advice services, it doesn't solve a structural problem, but in the short run, it gives you, it's something that can be targeted and can make a difference, which is why I made the comment about the devolution of the Department of Work and Pensions. So I think we need to think about things in terms of what are the things we can do in the short run that can make a difference in the here and now without neglecting the larger term inequalities that need to be addressed as a strategic issue.
Mae'r hyn yn bwyntiad ydych chi wedi gwneud yn dda iawn. Ewan Hilton?
Sorry, interrupting you. I would agree with that, but it isn't just the third sector that's been decimated financially. So have local authorities. And, you know, local authorities are our communities and where community stuff and prevention should happen. And they are on the bones of their backsides too. So this takes me back to this is a long-term project. Prevention is a word. We've got great legislation, great policy. We have the Future Gens Commissioner, but prevention is just a word for too many people. It isn't actually there. So this takes me back to it has to be funded. it is no use having 2-year transformation pots of money that actually basically go into local authorities or health boards to fill holes in current services. This is back to the 10, 20-year cross-government long-term commitment to a project to actually transform our systems so that they work in line with the rhetoric that we're so proud of in Wales, that is enshrined in our policy and legislation. It feels too much just like words.
Yeah. Diolch. Dr Daffyn, pan mae adnoddau yn bryn, a dyn ni wedi clywed yn fyna mae adnoddau wedi bod yn bryn, mae yna fwy o reswm byth wedyn ni roi ffocws clir i lle dyn ni'n defnyddio'r adnoddau yna. Ydy'r balans wedi bod yn iawn felly yn targedu y grwpiau sydd fwyaf angen i targedu, tra ar yr un pryd o bosib yn cadw llygad ar yr angen i roi negeseuon allan i boblogaeth gyfan?
I think we don't have a good public mental health understanding anyway. So there's probably, there's room for improvement. If we improved our public relational emotional health understanding, we'd see gains there as well. We don't have that in Wales anyway. So there's work to be done there. And councils are moving towards place-based approaches. So we said earlier that this is less about the who and more about creating the circumstances. And councils are seeing that, local authorities are seeing that, and organising things at a place-based level. I'd say that is true for mental health as well. So place-based community development that's trauma-informed is one way of organising scarce resource. So we know those communities that are more deprived are correlated to higher rates of everything, pretty much, for simplicity. Why not target them then to break that cycle and put extra resource there? We know they'll need extra resource to heal and to create the right circumstances that they need. So why not target those alongside a more informed public health narrative as well?
We talk about people and groups who are more vulnerable because of largely socio-economic factors. What about groups that are vulnerable due to particular moments in their lives? And I'm thinking of perinatal mental health for young mothers or parents. Are there groups? And there has been talk of perinatal mental health and need for investment there. Are there particular groups, points in lives that are being missed? I wonder, just a quick one, if you do have some thoughts on that, Dr. Daffyn.
It is a lifespan approach. Sorry, it is the lifespan. But yes, you're right. Getting those circumstances right early on will set people up, and then creating the ripple effect around them to make sure they've got support throughout life is important. But getting it right, that whole family approaches right early on are really crucial. The evidence base does sit around that.
Any Professor Poole or Ewan Hilton on sort of specific points in life, or if there's nothing in particular, I'll
the first 2 months. There is, sorry, the first 2 months.
No, carry on, Dr. Daffyn. I'll come to Professor Poole after. Yeah.
I'm sorry, just to say that there is evidence around the first 2 months, but it's an emerging area. So that perinatal period is really important.
Yeah, Professor Poole.
Agreed. I completely agree. There are all kinds of vulnerable points across the entire life cycle, right from birth to death, and that's just how it is. There are all kinds of groups of people who are neglected. I mean, we very rarely hear about travellers' mental health, for example, and actually there is evidence of major problems within travelling communities. So I think there are all kinds of groups. It does illustrate the difficulty in thinking about things in this atomized way. Yeah. There's a broad equality agenda here.
This next question from me, it's just to invite some thoughts of yours, really, because we can't possibly do justice to the topic. It's about workforce. So just maybe an overarching message from the three of you on the capacity of the specialist mental health workforce, but also the wider workforce in health and care to deal with and respond to all those different needs in terms of mental health and well-being. Do you have some overarching comments? You and Hilton, you have your...
I'll be very, very quick, and we can send you a report, and it's to do with some work we did during lockdown. We saw wonderful things happening in the system during lockdown, and we saw bad things happening, and we wanted to understand why. It came down to the culture within which people were working, not just the resource. It's about power, culture and leadership and values and psychological safety in the work that we are all trying to do. I will get the report sent over to you so you can have a read.
We appreciate that. Thank you very much. Dr. Daffin, where do you begin on the capacity of workforce, really?
Exactly. Everything we've said applies to the workforce. You know, we're not separate beings. Everything we've said in terms of what creates the right conditions applies to all of our systems, including those that we work in. Those that work with distress and trauma and mental health challenges have a particular exposure, and so should also be should have a particular we should give particular attention to that as well, and ensure that we're not re-traumatizing our workforce. Traumatized systems traumatize, and we know we've got lots of problems with resourcing and things within the NHS, but also local authority and our public systems generally. They're historically built on command and control, fear-driven approaches as well. So there's some real entrenched cultural issues to deal with as well to move to psychosocially healthy.
Thank you. And then Professor Paul.
I completely agree. We need to create a working environment that is, number one, is positive for the workforce's mental health, because we see quite a large number of people leaving our employment at our mental health services whose mental health has been damaged by various things that have happened to them. And I don't mean things that have been inflicted by the service users in any way, I mean by the system. We need to create a working environment that releases people's skills and allows them to use therapeutic relationships in an appropriate way, which is very difficult for many staff in the systems that we've built.
Mm. And it's also about, you know, making sure that the skills are there within that really sort of wider workforce. Teachers, for example, to deal with mental health issues.
Yeah.
Dr. Daffin.
Sorry, I was just going to say, yeah, it's about really understanding what relational health is and then applying that to practice and allowing our systems to be able to accommodate for that. So not being reductionist and, you know, process driven about results and things like that, but making it about relationships and putting those at the fore and front. And that's a massive mindset and cultural shift.
Yeah. Okay. Thank you. Well, we could go on and on that.
Thank you, Frian. Gareth Davis.
Thank you, Chair. And just to kick off on sort of Welsh Government strategy and take a direction in that way, the extent, I think, to which we need to address mental health inequalities, I think, is getting quite recognised now across Wales and also the UK government. And what's the benefits of a mental health in all policies approach? And I suppose that, you know, we could ask the question as well, you know, is it appropriate for the benefits of mental health in all policies to be there, and what specific policies do you think that needs to be incorporated in, and indeed which policies shouldn't they be if it's not deemed to be necessary?
Can I go first and be very quick, because I'm the only one in the office and someone's knocking on the door and I need to let them in? I would say that's what the current government strategy has got, but it's still failure demand. It's like more housing, more services, more this and that, and it's not addressing the social determinants. So I would actually say that what we want to see is addressing the social determinants of health and mental health running across all Welsh Government policy and legislation, not necessarily just mental health and responses to poor mental health. Is my short answer, and I'm going to quickly just
you go ahead and answer
the door.
No problem at all. Who else wants to come in? Dr. Daffin.
For me, it would be about understanding what is that. So, what do we mean by mental health, and is that the right term to use? Is that the right framing to give to this? If it's about creating the right circumstances, maybe we need to name what some of that is and use that to inform policy and ensure that policy and practice is organised around that. So, for example, what's going to create psychosocial healthy conditions? Agency, security, connection, meaning and trust, for example, and making systems relational and valuing relationships. If we embedded those across everything, it would be different to thinking about mental health. So maybe there's some more exploration on what exactly is it that we mean that's going to reduce the burden of distress on us that we often talk about as mental health.
From my point of view, the danger is of paying lip service in every policy, and it just becomes an incantation rather than action. The key issue here is that equality and social justice are public health issues, and everything that improves equality and addresses social justice is going to have an impact on physical and mental health. And that's the important thing for the Welsh Government. The really important thing for the Welsh Government is that we have got, for various reasons, a very unequal, a high level of inequality in Wales. And what I appreciate how difficult it is given the actions of the Westminster Government, but nonetheless, it's those policies that increase social justice that will make a difference in the long run, rather than simply saying, "Oh, we're mental health positive," which becomes one of those things you put on your letterhead and doesn't necessarily affect anything.
Okay, appreciate those answers. Thank you very much. And I know we're tight for time, so I'll keep it. I'll keep my next question short and just asking, what metrics should we use to measure action to improve mental health and reduce inequalities in Wales? You know, how do we measure that? You know, and where do we know when we've made a success and where the Welsh Government indeed needs to improve and enhance those sort of policy areas further?
So I think it's really easy to jump to kind of how an individual feels. Do you feel the service worked? Are you feeling happier or more hopeful for the future? And there's some value in that. We didn't, you know, we're only just getting a mental health data set in Wales, but the issue is it's still quite individualized. We need to be, I think, measuring, you know, real big whole country stuff to see if our strategies and approaches to addressing inequality and addressing poverty are working. And then we should see decreased demand on services. So rather than focusing on individual outcomes all of the time, I think we need some bigger indicators that help us understand whether the bigger actions we're taking about addressing those big knotty issues are really truly impacting on people's mental health and physical health.
Any other answers?
Thank you very much. It is actually surprisingly difficult to measure the impact of services, but it isn't so difficult to measure the impact of social factors. I'd suggest two things that will be important indicators. The first is the suicide rate. Suicide rates are affected by the economy, and they're directly affected by major social changes. And although suicide is not simply about mental illness by any manner of means, by definition, it is about mental health. So I think if we could see some shifts around, not necessarily compared with the rest of the United Kingdom, but in the secular trend in Wales, that is a reasonably sensitive measure of how government policy is impacting overall. There are major differences in suicide rates between different countries in the world. I mean, very big differences, like fivefold differences. The second thing is, in terms of our services and what happens to people with identified mental health problems, we should measure social outcomes. Social outcomes are much more important to people than clinical outcomes. We know that. There's an evidence base around that. People are concerned about how they live their lives. And if we put greater emphasis on how people live, then we're going to get a much better measure of how we're doing.
Thank you.
Thank you. And Dr. Daffin?
I agree with what Rob said. It's really it's complex, you know, and to suggest that we can influence and have control over everything in complexity it's not possible. But it's important to have some key markers. So just holding alongside that, the difficulty it is in measuring, because if we're talking about the negative end of that, but the positive end, how do we measure that people are thriving? It's a really complex task. It's a really difficult task. Some of the measures and some of the ways that people are exploring at the minute are storytelling, and using those methods for evaluation, but also for social change, and employing measures that can hold more complexity, and can help us understand what's the story of what's going on here. We need those alongside, and we definitely need those not just at the individual level, like Ewan was saying. They need to be broader stories that we're telling. It's because it's just really hard to do, to say, you know, this attributes directly to this, because of the breadth of you know, the social determinants are varied. They are very varied. There is a lot of stuff going on to consider.
Thank you.
Thank you all. This is a final question from me. At the end of this piece of work, we'll be producing a report ourselves as a committee, making recommendations to the Welsh Government. And I suppose I'm just asking you really all in bullet point form, tell us what you think the kind of key priorities are for us to consider, and tell us, in your view, what are the priority recommendations that you think that we should be making to the Welsh Government. Sort of asking you sort of bullet point form to help conclude the meeting. Ewan, I think you indicated there.
Oh, I was scratching my beard.
No, well you can go first for scratching your nose then. First.
I think the social determinants for health, social determinants for mental health, core to all public policy in Wales, cross-government commitment to that is what's going to make a difference, and a commitment to this is a 10, 20-year project. It is not a short-term fix.
Okay, thank you, Ewan. Dr. Daffin, key priorities for us as a committee, key recommendations you think we might like to consider making to the Welsh Government.
Improving public relational emotional health understanding, the public health response, extending the whole schools approach to a whole communities approach, and change starts with self. We need to ensure that we're embedding these principles in our politics and our way of doing policy, and in this forum as much as we do in the other forums as well. So putting that at the heart of everything we do here as well.
Okay, and just before I come to Professor Paul, if there's any other members that have got anything pressing, a very brief last question, then consider that as well. Professor Paul.
Right, bullet points. Number one, prevention. Prevention is possible. You don't need to have a massive, complete elimination of mental health problems. A few percentage point reductions in rates makes a big difference. Prevention. Number two, evidence. That you should follow evidence, and when the evidence is inadequate, we should gather new evidence. And I mean evidence in a broad way. We need empirical, quantitative evidence. We also need qualitative evidence. Number three, access. People should be able to access help when they need it, not after some long delay. Four, that we measure social outcomes. I've made that point already, that our measure of success should be social outcomes. And finally, that whatever help we offer people should be founded upon relationships with communities and with individuals.
Thank you very much, Professor Paul, and thank you all for being succinct in those final messages. Really appreciate that. Any other members, any final pressing questions? No, don't think so. Thank you. In that case, can I thank you all very much for your time today? Very much appreciated, and for your written evidence that you provided to us ahead of the meeting. So thanks ever so much. And we'll send you a transcript of proceedings from today. And if you want to add to anything, then please do, if you think it'll be helpful for our work. But diolch yn fawr iawn, thank you very much for being with us today. We're going to move on the meeting now, but by all means, leave as you feel appropriate. So thanks very much.
Thank you very much.
Thank you very much.
Thank you.
Thank you all, and move to item 3. There's a lot of papers to note